Thank you, Dr. Bach. Dear colleagues, I'm Dr. Han. It's a great pleasure to have this opportunity to share my experiences. For the next 20 minutes, I will speak about immediate loading of any reach and a little summary of my presentation in Jeju Symposium last year. Patients today want the final result sooner rather than later. And the main issues of implant dentistry in these days are focusing on the reduction of initial healing period. So we have to know the changes of implant stability in initial healing phase. But there are few objective methods to evaluate implant stability. The most common, simplest, and probably most inaccurate test was percussion test. And perio test has been used for years, but it can be only used for restored implant or mounted abutment. And we can check the insertion torque at the time of implant placement. And we can check the ISC values at the time of implant placement and during healing phase with OCell device. For the last 7 years, I performed resonance frequency analysis using OCell device to all the implants that I placed. OCell can provide reliable data about implant stability. Without this kind of test, you have to depend on your personal experiences or follow the conventional Graham-Marx protocol. Let's see the resonance frequency measurement. This is SmartPack, and SmartPack was screwed into the implant, and resonance frequency analysis was performed with a OCell device. Usually, double measurements were made for different directions, and the average of ISC values was recorded. Yes, the measurement of ISC values has become an important tool to objectively examine the implant stability in my daily practice. And now, I've been using the new version of OCell device, Mega ISQ. Mega ISQ was designed by MegaGen, and it is very easy and very simple to use. And you can easily check the ISC value through the large LED panel. Let's go back to the point. According to many articles, implants showed the weakest anchorage and the lowest ISQ value in the first 3 weeks. And ISQ values show some fluctuations until the 6 to 8 weeks, and then ISQ values were restored 8 weeks post-surgically. So this kind of graph can be found in the most of implant systems. Then what about ISC values of any reach? In this case, both molar area were grafted 4 months ago. The bone quality was not so good. So I skipped the last 2 drilling sequences for 5mm implant. So you can see the very small osteotomy at the molar area. And immediate implant placement was done in maxillary central incisor area. Then I measured ISQ values immediately after implant installation and at an interval of 1 week. In this situation, NRH showed stable and increased ISQ values even in the first 3 to 4 weeks. So the final prosthesis can be delivered 9 weeks after implant installation. Why are the NRH showing this unique pattern of ISQ values? I think I attribute this to macrostructural NRH, especially thread design. Yes, it's not flat. I was presenting this in Jeju Symposium last year. The average ISQ value of successfully osseointegrate enriched implant was over 70. And this value can be the guideline for prosthetic restoration of any ridge. And I was also presenting this. The average ISQ value of enriched implants, which showed insertion torque above 40 neuron centimeters, was about 71. And I proposed this as threshold values for immediate loading of any ridge. But when it comes to immediate loading, I think high insertion torque is more essential. And I performed immediate loading of any ridge with these values, and I got good result. Let's see this case. This patient was very scared with surgery. Fortunately, she had relatively enough bone width on molar area. So implant was placed with Fleming's technique after bone-added austerum sinus floor elevation. Insertion torque was 45 neuron centimeters, and ISQ value was 76. Final prosthetics was delivered 1 week, just 1 week post-operatively. And ISQ value was increased to 79 at that time. By the time, Dr. Kim, there's Dr. Kim, Artugate man. Dr. Kim was asking me a question. Hey, Dr. Han, we knew the ISQ values of any ridge in unloaded situation. Then, what about ISQ value of any ridge in loaded situation? I answered, I don't know that, but I can figure it out. To answer this question, I decided to unscrew the final prosthesis and measure the ISQ value at an interval of 1 week. Actually, to unscrew the final prosthesis after immediate loading is very dangerous and very scary thing. But I had to do it because he's my senior. And this is the result. As you see, ISQ values were very stable with time, even after being loaded with final prosthesis. I like this case, and I like Dr. Kim, because this is my first case that I measured ISQ values after loading. How about mandible? In mandibular hillside, enrich was placed, and final prosthesis was delivered 1 week post-operatively, and unscrewing the prosthesis and measuring ISQ values were performed too. In the mandible, ISQ values were also stable and gradually increased with time. It's amazing. In this case, all implants showed insertion torque above 40 neuron centimeters and ISQ value above 80 at the time of implant placement. So the final prosthesis was delivered 1 week post-operatively for all implants. And ISQ values were measured at an interval of 1 week as the same way. As you can see, all implants showed stable ISQ values, and I happen to know that if implant got strong initial stability at the time of implant placement, there are no striking changes of ISQ values, even after loading. How about this case? I plan to install any ridge immediately after second molar extraction. These are pre-simulated any ridge in CT scans. Second molar was removed, and you can see a large bone defect. So I was harvesting blood bone from the posterior mandible, and blood bone was placed on defect area, and fixed with periosteal elevator while implant was placed. Both implants showed good initial stability. Insertion torque was 15 Newton centimeters, and ISQ value was over 75. That means I'm ready for immediate loading. So final prosthesis was delivered 1 week postoperatively, and ISQ values were measured as the same way. Look at the red line. Surprisingly, ISQ values were very stable with time, even in immediately placed and immediately loaded implant. And implant showed favorable result during follow-up period. I reviewed my data about ISQ values of any reach, and there were no statistically differences of ISQ values between immediate implant placement and delayed implant placement. So I'm trying immediate loading after immediate implant placement with final prosthesis in these days. Let's see this video. Drilling sequence is very simple when you are using trapline drill. And some final drill can be used. And I've been usually using super wide any reach in case of immediate implant placement at the posterior area. Super wide any reach has been always offering excellent initial stability. Insertion torque was measured, and ISQ value was also measured with a cell device. Yes, this is mega ISQ. Double measurements were made, and the average of ISQ values was recorded. Then, the gap between implant and extract socket was filled with autogenous bone mostly. And final prosthesis can be delivered 1 week postoperatively. So this is not just an immediate loading. So I decided to call this loading protocol as X-speed loading. Implant was placed immediately. This is also super wide any reach, and initial stability was very good. So final prosthesis was delivered 1 week postoperatively. As you can see, implant showed good result during follow-up period. Actually, 6 months is not a long-term follow-up period. But after initial healing phase, implant survival is mainly depending on occlusion and maintenance. Even in infected molar area, if you use any reach, and if you get strong initial stability, I'm sure X-speed loading can be possible. And now I propose insertion torque above 15 Newton centimeters and ISQ value above 80 as threshold values for X-speed loading. And I promise I will show you more cases and follow-up data about X-speed loading in the symposium. You had already saw this picture in Dr. Lin's lecture yesterday. There may be many biomechanical factors even we still don't know. But the obvious thing is there is no decrease of any ridge's stability. So immediate loading after immediate implantation can be possible. But I never promised immediate loading to patient because if implant goes to bed after promising immediate loading, then what am I supposed to do? 40 and 70 or 50 and 80, these are just numbers. These are threshold values for immediate loading of any ridge that I proposed. You should have your own strict rule for immediate loading. And I think the key point of immediate loading is how to get a reliable initial stability with this special implant system. In this point of view, the next speaker, Dr. Lee, will show you the secret of initial stability. Thank you very much.